Hi, I'm Madeline Atwood, and along with Leslie, Ashley, and Megan, we did our research project on cultural and linguistic barriers in nutrition and health literacy in women. The purpose of our study is to investigate the possible correlation between cultural and linguistic barriers in healthcare and health and nutrition literacy in women across different races and ethnicities. To test this knowledge, we conducted a survey with questions regarding nutrition and health information to assess literacy. I thought I would start us off with our research question. Do cultural and linguistic barriers influence health and nutrition literacy amongst women from different racial and ethnic groups? We completed a cross-sectional study over a month-long period of time where we collected data through an anonymous online Qualtrics survey. Questions that were on our survey were put into different categories, including demographics, social factors, nutrition knowledge, food label, food groups, consumer skills, and linguistic and cultural questions. We then sent our surveys out through emails to the department heads of Metropolitan State University Denver, social media, and flyers that were posted on the MSUD campus, as well as a diabetic education center. We ended up recording 163 responses. However, when we concluded, we only had 160 fully completed surveys. Our study population then consisted of 116 adult women ages 18 and up. Our efforts were to recruit women who spoke different primary languages, including but not limited to English, Spanish, Vietnamese, Arabic, etc. Next, we're going to have Megan go over our statistical analyses.
Hi! So for our statistical analysis, we ran chi-squared tests through the SPSS software to assess any relationships between our independent and dependent variables. Our goal was to observe any significant differences in health and nutrition literacy and experiences with healthcare workers depending on speaking English as a primary language or speaking something other than English as a primary language, whether it be Spanish, French, Vietnamese, etc. We also wanted to test any significant differences in health and nutrition literacy and experiences in the healthcare field across different education levels. Our education levels ranged from completing some elementary school to completing college level degrees. To assess, this is going to be a little bit of review, but to assess knowledge, we created a test that covered basic nutrition information, and to assess experiences and attitudes, we created 14 yes or no questions that spoke to experiences and attitudes in the healthcare field. Things like dealing with healthcare professionals, understanding information that was relayed to them, and needing translators or dealing with language barriers, all of those things that can affect health and nutrition literacy. Okay, so on to the results. Our study population consisted of 116 women, ages ranging from 18 to 60. Our highest completed education level ranged from elementary school to college level graduate. Our household income level ranged from below $30,000 to above $150,000 annually. And of the 116 completed surveys, we ended with 82 women who speak primarily English, that's their first language, and 34 women who spoke either Spanish or an other language as their primary language. Some other languages that we recorded were Arabic, Farsi, Portuguese, and Romanian. Okay, so on to the fun part. So these are the results from our chi-squared tests that we ran through the SPSS software to assess any significant relationship between our independent and dependent variables. So, for our primarily English speakers, we recorded a significant relationship between test accuracy, the test being our basic nutrition questionnaire, having access to information in their preferred language, along with having doctors and nurses being able to speak to them in their preferred language. For our Spanish and other speakers, there was a statistical significance with test accuracy, the same basic nutrition questionnaire, having access to information in their preferred language, having doctors and nurses and other healthcare professionals being able to speak to them in their preferred language. And then some things that we did not see in the English speaking group are things like needing a translator to be able to translate health and nutrition information to them, and feeling unable to seek medical attention because of a language barrier. And then lastly, for education, we recorded a significance between test accuracy, the same basic nutrition information, and having access to information in their preferred language. In the future, we will be doing tests comparing age and income levels with the nutrition questionnaire and our yes or no attitude questions, and seeing how that could affect that as well. But I will hand it over to Leslie, and she will wrap everything up and talk about our conclusions.
Okay, so now we continue with the conclusion. As we saw from results, cultural and linguistic barriers do affect nutrition and health literacy. This might not be a surprise to many. English speakers scored higher in test accuracy and reported fewer barriers. Also, Spanish and other language speakers faced more challenges like translation needs, limited access to info in their preferred languages, etc. Education level does influence accuracy and literacy, and some of the not significant were the ability to ask questions, the ability to understand medical information, and also some of the cultural foods that they were present. So we can also conclude that cultural and language are intertwined barriers, and one often reinforces the other. Improving language-appropriate, culturally sensitive healthcare communication is essential to reduce disparities among the population. Okay, so to end the conclusion part, I do have a couple of questions. Please feel free to answer at least two of these. Did you expect these results, or were they surprising? Do you think this research is relevant, or is it information you already assumed or knew? Also, how can health providers better address cultural and linguistic barriers? And what strategies could improve access to nutrition and health information for non-English speakers? Do you think education level or language plays a bigger role in literacy outcomes? And how can future research expand on these findings? Please let us know what are your thoughts, and we'll be here to listen.
My name is Ashley, and I am presenting Implication to the Field and Future Direction. I have 3 slides. On the first slide, I will discuss culture influencing nutrition and health literacy. On the second slide, I will discuss linguistics influencing nutrition and health literacy. And it's important that we study language separately from culture in literacy research, because although associated, language influences comprehension and communication through its own distinct mechanisms. And then on the third slide, I will discuss intersectionality with women's health. When investigating how culture influences nutrition and health literacy, it's important that we examine how culture shapes health literacy and nutrition knowledge, influencing health beliefs, communication styles, preferred food practices, and socioeconomic factors. which can affect a person's ability to understand and access health information and services. As professionals, we can explore client culture by being interested in them and asking open-ended questions to learn about their food traditions and beliefs. It's important that we explore how acculturation affects dietary behaviors. Acculturation has been linked to poorer nutrition, increased tobacco use, and substance abuse, suggesting potential contributions to health disparities among Latinos. While recent immigrants tend to have better mental health, U.S.-born and more acculturated Latinos report higher rates of mental health issues such as depression. The overall impact of acculturation on Latino health remains unclear. To investigate the effects of acculturation, we can use both qualitative and quantitative methods, and in our professional roles, we can explore acculturation by asking clients to self-report their behaviors and then comparing their behavior change over time. Thirdly, it's important to identify ways health systems can integrate cultural and linguistic considerations. Clinicians and healthcare staff have an important role to play, but the responsibility for achieving real progress for patients facing challenges related to literacy, culture, and language must extend to the organizations that support them, including systemic integration, training competency, and health equity. When investigating how linguistics influence nutrition and health literacy, it's important to develop and evaluate strategies for communicating health and nutrition information to women with limited English proficiency and low native language literacy. It's important that we evaluate our communication approaches beyond translation, focusing on how to simplify and effectively communicate complex health and nutrition information in various languages. Not only translating it, but also adapting text and images to resonate with the target audience's cultural norms, beliefs, and motivators. It's also important that we evaluate to see if the method resulted in improved behavior and health outcomes. It's important that we identify and address hidden linguistic and cultural barriers affecting women's health. For example, in high context cultures, patients may avoid asking questions and agree with providers when they don't understand. This could be due to respect for authority, fear of being a burden, indirect communication styles, or even mistrust in the medical system. We wanted to study women as an underrepresented population in nutrition and health research, so I feel it's important to discuss intersectionality with women's health and incorporating an intersectional approach, considering multiple overlapping identities such as race, gender, language, and socioeconomic status, shaping a woman's experiences with health and nutrition literacy. It's also important that when we do research, we disaggregate our findings by social categories rather than presenting data for women as a homogeneous group to clarify the subtle determinants of health disparities. It's also important that we incentivize research that includes and reports on diverse populations. Policymakers and funding agencies should require and incentivize research that includes and reports on diverse populations, ensuring that research findings are relevant to a wider range of women. Advocacy plays a critical role in shaping health policy. It's also important that we utilize methods like community-based participatory research to ensure inclusion and relevance, empowering women from diverse backgrounds to define and address their own health priorities related to nutrition, ensuring that interventions are both culturally appropriate and effective.